Okay, we are now live.
Okay, thanks. Tracy, we're dead on 7 o'clock, so I'll start. Welcome everyone to June Health in Hackney. Just to remind everyone, this meeting is being broadcast live on YouTube and it's also being recorded. Members of the press, I understand, are watching. Can I ask that everyone mutes themselves when you're not speaking so as to prevent feedback? But if possible, keep your camera on. If you wish to speak at any particular point, maybe if you can try putting up your hand. I won't be looking at the chat function much, if at all, throughout this. So please don't rely too much upon that. Very briefly, I've had one apology from absence from Simon Galinsky from Hackney Council. I've got no urgent items, and I've already asked members, and there are no declarations of interest. So with that, I'll now move on to the main item for today, which is item 4, and our discussion with respect to COVID and what more local authorities can do to mitigate the spread in their areas. In Hackney, there have been at least 175 COVID-related deaths, but if we were to look at in-excess mortality, the number is likely to be far higher. 69% of those that passed away were born outside the United Kingdom, compared to 37% of Hackney's total population. Councillors in Hackney, and no doubt across the country, are keen to do everything they can to mitigate further spread of this virus. And the purpose of this meeting is to try and tease out specific suggestions that we and other local authorities can implement locally. We're joined by a distinguished panel of guests who I'll introduce in turn when it comes for them to speak. I'll ask each speaker to speak to us for 10 minutes each, and then at the end open it up for questions from the councillors on the committee and our local health leads. The first person we have to speak is our very own Director of Public Health, Dr. Sandra Husbands. Hackney, along with Newham, Camden and Barnet, were one of the 11 pilot or beacon boroughs for the recently announced Test and Trace programme. And Dr. Husbands is going to talk to us about how that works from what we know at the moment, and also the challenges we currently have with the lack of data that we currently get. So, Dr. Husbands, over to you.
So, thank you, Councillor Hayhurst. And good evening, everyone. So I'll just give a quick overview as well of how the national NHS test and trace system is working, because we need to understand how what we're trying to do at local level in local authorities and in what we're now calling the good practice networks, these 11 groups of local authorities working together on this, are how that fits together with the national NHS test and trace. So some of you will know all of this, and some of you may never have heard of it, and some of you might just be confused. So hopefully at the end of this you'll be less confused. And if I get it wrong, Kevin can correct me. So NHS test and trace is basically a kind of souped up version of the normal Public Health England contact tracing system, where they've created additional capacity around their normal specialist public health, PHE, health protection, contact tracing function by bringing people together, and also by looking to bring some additional capacity in, and that's level 1. They're going to focus at level 1 on dealing with outbreaks in complex settings, or complex outbreaks perhaps. So if there's an outbreak in a care home, for instance. Then at level 2 and 3, these are the levels that you'll have probably heard about in the news, where there are these thousands of people who have been recruited recently. Level 2 are health professionals who have been recruited and trained to follow up cases. So these are cases being people who've had a positive test for the SARS-CoV-2 coronavirus. So these are cases who very specifically meet the case definition because they've got a positive test, and they'll be followed up either by putting their information into a web tool themselves or by being phoned by one of these level 2 contact tracers. And at that point, they can get more advice or details about what to do, how to self-isolate, but also, really importantly, then information is gathered from them about people that they've been in contact with during their sort of infectious window. So that's which starts about 48 hours before they become symptomatic, up to the point that they started to self-isolate or had this phone call. And then the next load of people, the level 3 call handlers, will contact the contacts, follow them up and tell them that they've been in contact with someone who's had a positive test, and advise them how to self-isolate for 14 days and what to look out for in terms of symptoms, and that if they do become symptomatic, that they also need to get tested. So that all sounds very simple, doesn't it? And straightforward. And in one sense, it is, because this is a very tried and tested method. What's different about now is the number of cases that we have of coronavirus. Normally when we're dealing with outbreaks, it might be a relatively small number, outbreak of chickenpox in a nursery or something, and it's in a relatively confined location. What's different now is that it's all over the country, it's all over the UK, as well as all over the world. And the really high numbers, certainly the really high numbers that we had during the peak of the pandemic, and the potential for those numbers to get high again if we don't get on top of it with contact tracing. So linking into that, at local authority level, we are developing local outbreak control plans. Now, I say that, and I said it in that rather hesitant way, because we are writing these plans now because we've been asked to, but it's not as though we've been working in an unplanned and an unthoughtful way up until now. So right at the beginning of the outbreak, back in the beginning of March, when at that point our understanding of this coronavirus pandemic was quite different from what it is now, and we were advised by Public Health England to refresh our flu pandemic plans. We got our flu pandemic plans out and refreshed those and looked at them and made sure they were up to date. But we also actually already understood that it wasn't exactly like flu. And here in City and Hackney, we actually created a COVID pandemic plan, and started putting together the governance structures, as well as what everyone else has done probably in most local authorities. They stood up a strategic command group and brought together all the relevant emergency planning so that we could effectively manage the we could effectively manage the outbreak, as well as the associated issues to do with both protecting the NHS in the early days, and then later, obviously, with the lockdown, the issues around supporting people who were either furloughed and not getting enough income, or perhaps laid off, or unable to manage because of other vulnerabilities, but during the lockdown period. So we've been doing that all along, but now we're in a different phase where we're doing two things in parallel, and one is working out a plan that helps us to work more effectively now that the national system's gone into this test and trace phase, so that as they are identifying people who they're following up, and they're following up contacts, and perhaps identifying small clusters or outbreaks in our locality, we'll be able to support that, whether that's in a school or a care home or within a particular community, as well as starting to plan for the phase beyond, as the lockdown measures are progressively relaxed and more people are out and about, principally working through our communities, working with our community partners actually to help get the messages out there that not just the ongoing message about what coronavirus is and how you can be exposed to it and what you need to do, what to look out for in terms of symptoms, but also, really importantly, the message that doesn't appear to have been getting through very much in our local population, which is to get tested if you have symptoms, as well as to self-isolate, and also that to work with our communities to generate some trust in the test and trace system, so that if people are contacted by somebody from NHS Test and Trace, they know that this is a trusted body that giving your own information, but also providing information about contacts, is about the common good and about preventing the onward transmission of the virus, and is not about the government gathering data about you so they can do something with it later, which is a fear that has been expressed several times in some of our local communities. So that's some of the work that we've been doing. And I think I'll stop there because I don't want to go into too much detail or talk for too long.
Thanks, Sandra. That's very helpful. Just before I move on to the next bit, can you just because we had a conversation on Friday, just so I could try and get an understanding about at the moment what data we are, as a borough, we are getting from the national system. And as I understand it at the moment, what we're simply getting is a figure every day of how many people have tested positive. We don't know when that was, who they are.
Yeah.
And we're also getting 2 line items as to the number of people who have been through the track and trace system who have been tested positive through that, and the number of contacts, but again, no specific name, address, detail. So is that still the picture, and are we anticipating more data to come through from the national structure?
Right, yeah, so sorry, I did forget that was the second part of the brief. So yes, that's right. So we are getting data, and to give Public Health England some credit, they have been doing some work on trying to give us both more timely data and more detailed information, and there are some constraints, information governance constraints, about the kind of information that we can be provided with. But I, as a local director of public health, though, I do find that just being told this number of people, there were this number of positive tests, and that we followed up, and that we completed contact tracing on this many in your area, is not particularly useful information. It doesn't help me to know what the context was. It assumes that it was not a complex setting, but without having any further information about it, neither they nor I can know whether it was a complex setting, because they can't necessarily identify that it was related to a care home unless the person tells them, or that it was related. So if it was somebody who worked for a care home, or in a care home, or occasionally worked in a care home as an agency member of staff, but when they rang up and were asked about details, they didn't perhaps convey that particular information, then Public Health England wouldn't know, and I wouldn't know. So I think there are some issues about the fact that the information that we get is quite sparse in terms of helping us to understand what we can do locally to really get on top of things and help prevent the spread, and also to support the settings where these things can occur. And it doesn't even have to be an outbreak. It could be an individual case where the people in the organisation just need some supporting in knowing what to do, not just in terms of should we call Public Health England or not, which is one of the questions they always have, but what else do we do? Do we need to close down? Do we need to do a deep clean? And they don't necessarily know what to do next. And we could more easily provide support to people proactively if we were more in touch with what was going on.
Thank you, Sandra. I think there will be some questions in due course about some of the things you've said. But I'd now like to move on to the next speaker, Professor Fenton, who's the Regional Director for Public Health England in London, and also the Regional Director of Public Health at NHS England. He has recently contributed to the report on disparities in the risks and outcomes from COVID. And one of the findings of that report was that people from ethnic minority communities are more likely to be diagnosed with COVID. So some of the questions we have for Professor Fenton is, why is that? To what extent do structural inequalities play a part? And going back to the initial introduction to this meeting, what specific recommendations do you have for us? Professor Fenton.
Great, thank you so much, Ben, and good evening, everyone. It is a real pleasure to be here with you this evening and to have a chance to reflect on the COVID pandemic and its impact on London, and more specifically, its impact on Black, Asian, and minority ethnic communities. There have been a lot of lessons that we've learned in this first phase of the epidemic, and as we prepare to lift restrictions from the lockdown phase to enter a new phase of the epidemic, it's really important that we learn the lessons of what worked and what could be improved and what can be done to protect our communities moving forward. So in the time that I have available, I wanted to do three brief things. First, to do a little bit of reflection on the epidemic in London, because it provides context to the impact on BME communities. Second, I'm going to speak a little bit about the BME review, the disparities review, which was published last week by Public Health England. And then finally, I'll reflect on some key recommendations emerging from that work, but also which have arisen from the extensive stakeholder engagement which we undertook as part of that work. So firstly, just to reflect a little bit on the epidemic in London, it is important for us to acknowledge that over the past 3 months, more than 26,000 Londoners have been infected with this disease, and we've lost nearly more than 6,000 Londoners to this infectious disease. And we know that the infection hasn't been randomly distributed in our city, and that certain groups have borne the brunt of the epidemic, which include older individuals, men more than women, and certainly some Black, Asian, and minority ethnic communities. We know from the epidemiological data and its distribution in London that more deprived, socioeconomically deprived parts of the city have also been severely affected as well. So it's within this context then that we are thinking about population health and the future health priorities in our city. And in my mind, I think there are 5 key things that I'm particularly looking forward to advancing and working with you all on in the weeks ahead. The first is, how do we emerge from the epidemic, this first phase of the epidemic, and we deal with a number of the health issues which are going to emerge as a result of having gone through the extensive lockdown period, the direct impacts of COVID, and of course the impacts of the economic devastation that may well result for many communities within our city. So really thinking about how do we get back on track with recovery and support health and well-being. Second, COVID has not created inequalities, but it has widened these inequalities, and it certainly has shone a light on these inequalities in our city. So second priority for me, working with you all, will be what more do we need to do to accelerate our efforts to address and tackle health inequalities. Thirdly, as we think about some of the big health challenges which pre-existed COVID, these health challenges remain. So whether it is cardiovascular disease, cancer, thinking about issues related to mental ill health, these are big issues for Londoners, which we will now need to be addressing within the context of living with COVID. And this will present some unique challenges for members of our city, residents within our city. Fourthly, ensuring that we have good data to help us to understand the epidemic, but also to respond effectively. And I want to support Sandra's comments about the importance of getting data that allows us to understand our local epidemics, to know our local epidemics, so that we can respond effectively. And the fifth priority moving forward from the first phase of the epidemic will be ensuring that we are using all of the tools available to ensure that there's maximum suppression and elimination of the virus within our city. It is incredible that London now has among the lowest numbers and rates of COVID in the country. So as a city, as a region, we've done fantastically well in controlling the epidemic, despite it being having hit the city relatively severely. So the question is, how do we ensure that we're working with communities to promote both the personal protective strategies, whether it's hand washing, avoiding touching your face, staying home if you're unwell, straight through to the things that we should be encouraging communities to do to protect each other, which may include isolation if unwell, wearing face coverings, right through to some of the structural things that may be necessary. For example, lockdowns at local levels, and thinking about ways in which we support communities to reduce transmission. So now we have a range of tools available in the toolkit to control COVID. The question then becomes, how do we implement these with communities effectively moving forward? Now, the second thing I wanted to reflect on, having just sort of touched a little bit on the epidemic in London, is what do we know about inequalities for Black, Asian, and minority ethnic communities, and inequalities in general for COVID. So PHE's Inequalities Review, published last week, really highlighted that, again, looking at the epidemiological data from health service access and utilization, as well as mortality statistics, we know that COVID has this disproportionate impact, where age is perhaps one of the areas where we have the most glaring disparities, with those who are 80 years or older being nearly 70 times more likely to die than those under the age of 40. But we know that the risk of mortality is also higher among males than females. It's much higher in more deprived parts of the country than in the less deprived parts of the country. And we know that their mortality among some Black, Asian, and minority ethnic groups vary significantly. We know that BAME communities are more likely to be diagnosed with COVID. Once diagnosed, they're much more likely to have severe disease, and they're also more likely to die as a result of their infection. Now, the PHE study was able to look at factors such as age, deprivation, region of residence, to see whether or not, once controlling for those factors, whether or not this would explain the differences that were observed in racial and minority ethnic groups. And the analysis showed that they did not fully adjust for these changes. In fact, that even when you adjusted for these characteristics, there was still excess mortality and excess severe disease among some Black, Asian, and minority ethnic communities. Now, this may be explained by other factors that weren't accounted for in the PHE analysis, but it may also be reflecting of some of the wider social, cultural, economic, and structural factors which are influencing risk. And a key part of understanding what those wider factors are really came from some of the stakeholder work that we did. And over the last 6 weeks, I've had the privilege of engaging more than 4,000 individuals from all across the country, from national, regional, and local levels, working in the devolved nations, working in local government and national government, to understand what are some of these contextual issues which are driving that excess risk among Black and minority ethnic groups. Now, I won't have time to go into any detail today with those findings, but I think there were four key things that really struck me from the really passionate and engaged and committed conversations that we had with stakeholders. So first was the risk that social and economic deprivation plays on the role of vulnerabilities of communities. And those vulnerabilities can have a huge impact on how COVID it becomes rooted within communities, how it therefore gets transmitted, and the impact that it will have. So any conversation about actions must take into consideration those social and structural factors, which we know are a core driver of poor outcomes with COVID. A second key reflection from the stakeholder work was that there are factors which uniquely are increasing the risk of exposure of to COVID among BME communities. So for example, the occupational risk, whether you're a key worker coming into contact with many individuals like taxi drivers or bus drivers, or you're a key worker working with people who are likely to be infected with COVID. These are things which will increase your risk of exposure. And it's really important for us to understand how BME communities are perhaps at higher risk by virtue of what they do and how they interact with their communities. Third, we need to be thinking about ways in which factors which can increase disease severity, for example, uncontrolled diabetes, obesity, hypertension, and cardiovascular disease, well documented in the literature. And this we learned from the stakeholder engagement were really important things influencing risk in the community. And then finally, some of the structural issues, including racism, discrimination, stigma, distrust, fair, issues which Sandra has already mentioned, which I know all of you are well acquainted with. These are real issues which were challenging, certainly for the community, and are seen as being underpinning some of the disparities which we see not only for COVID, but other health conditions. So any conversation about what we need to do, I think, should take into consideration these things. So my final sort of brief contribution then is just to think about what exactly do we do with this learning and where do we go next in terms of making that difference. So as I think about what needs to be done, I think of pace and I think of impact. We now are coming out of the first phase of the epidemic. We need to ensure that our communities are resilient and are prepared and have learned the lessons as we prepare for perhaps a second wave in the autumn. This means that we should be looking at how we engage, for example, with culturally competent messages around prevention, around taking control within communities, around steps they can take to prevent this transmission and acquisition of COVID. And that might mean looking at how we begin to engage communities around taking up testing, around contact tracing, around social isolation, and what are some of the real social and structural issues and messages that we need to be encouraging with our communities. Second, because we know that chronic, uncontrolled or poorly controlled non-communicable conditions or multiple long-term conditions such as diabetes, obesity, uncontrolled hypertension can have a significant impact on worsening your clinical course. What can we do to ensure that we are promoting health, promoting well-being, encouraging better control of these conditions, and working with the NHS, with services to really focus on improving health, well-being, mental health, and resilience, both in the short term as well as in the longer term. And then finally, because of the very strong links between economic well-being and physical and mental well-being, and emerging from this first phase of the epidemic, I would certainly want to think about what are we going to do to support the economic well-being of our communities as a key element in improving the social and structural context within which communities are going to have to rebuild, restart, recover, and build a resilience for the journey ahead. So, colleagues, I'm going to pause there. I've used my 10 minutes as allocated, and I'm looking forward to your reflections and your questions from my contribution. Thank you very much, Ray.
Thank you very much, Professor Fenton, for those insightful remarks. We next have Professor Anthony Costello. He's a member of the Independent SAGE Group and a former Director of the World Health Organization. Today, the Independent SAGE Group published a further report on integrated find, test, trace, isolate, and support. And he's going to talk to us about some of his thoughts in terms of best practice in relation to those areas. So, Professor Costello, over to you. Professor Costello, you're still on mute.
Sorry. Thank you very much. It's really good to be here. I've got a presentation, whether this is going to work or not, and if Jarlath, what I wanted to do was just talk about what do we mean by test and trace, as the NHS call it, or we're calling it find, test, trace, isolate, support. It's very important to know why we're doing it, and then to look at some of the key issues that we think are actually both crucial and possibly missing from some of the initiatives so far. And my colleague Alison Pollock will follow up on some specifics relating to that. I don't know if you've got the presentation. If that's going to be too difficult, I can talk. Here we go. Oh, brilliant. So, that's the end. You might want to go back.
I'll go back, yeah.
Just keep going back, yeah. So we start with a virus, a new virus, which emerged in December, probably from the wet markets of China, probably from bat transmission, although there are rumors of, the theories of leakage from laboratories and the like. Next slide. And it was pretty clear by the third week of January that firstly, this was very transmissible. It had already spread across China. and indeed into 17 other countries by the end of the third week of January. And clearly it carried a high case fatality rate. So at that point, people were getting very edgy and realizing that this could be the big one. Next slide. And of course, the symptoms are mainly about, you know, trouble breathing or headache, fever. Sudden loss of taste of smell is quite a characteristic feature of this, but cough, fever, feeling unwell, difficulty breathing, a whole range of symptoms. So it can be a little tricky to define it absolutely on symptoms. And of course, as we go into the winter months, that may be a problem if there is, for example, influenza or other chest infections and the like. But there are some fairly characteristic features of this condition as well. Next slide. So the principles of control were laid out very well by the World Health Organization at the end of January and the beginning of February, which is you need to find people with symptoms, test them if you can, trace their contacts, really focus on isolation, because if you don't do that, it hasn't worked, and make sure they're supported, add in social distancing, but crucially, do it all at speed. And that was the message repeated daily by the World Health Organization. And there were behaviors associated: washing hands, coughing into a tissue, don't touch your T-zone, which is across here, and masks. Now, the Asians, of course, have always used masks. They thought we were completely mad not to. There are people here that have queried the evidence, and there is still some debate. But I personally think masks are good. Alison may have some more reservations, because there are reservations to be had. Go on to the next slide. And Korea in February, if you look at that graph on the upper right, around the 22nd of February, they had their second and third deaths. And at that point, they had prepared themselves to ramp up testing, which they went up only to below 20,000 tests a day. And they really hit that very fast. And they got their epidemic under control within about 3 weeks. And they've ended up with 250 deaths. And they reported all of their data by province daily to everyone from February. So they had a website that everyone visited. Next slide. Now, this is in our report, we talk about the components, and I won't go over this very much, but just to say time's of the essence. You've got to find, trace, and ask people to isolate within 4 days for that, of that person getting symptoms. So about 2 in 5 people infected will not get symptoms. We believe now, and WHO believes, that very few of them actually transmit the virus. But the key thing here is you need a public information campaign to make sure people know about symptoms and know what they need to do, and they need to get tested. And I'm not sure that that is being sufficiently done at a local and community level yet. Next, you've got to make it really easy for people to get a test. Just down that slide, yeah. And you need to get the results back within 24 hours, because you will have had a couple of days of them knowing to get a test. You want to get the test back so that you can then also contact people and make sure that the contacts isolate. You ideally need 80% of the contacts to be traced. Ideally, you should have trained people within local communities doing that, because that's what most other countries have been. And for isolating is absolutely crucial. You can't just assume when you say to people, oh, you're going to isolate, that that's going to be enough. You've got to give them the financial support. You may need to give them facilities, and you need to give them reassurance and follow-up. And we'll talk about support. So carrying on, the issues that we raised in our report. Next slide. The first one is that you cannot run this from a national program. You have to have local component. You have to have directors of public health, local authorities, especially GPs, but also others, commissioners, labs, school nurses involved. And you want that because it's local, it's integrated, it's sustainable. And this is going to have to last for quite a long time. This could be with us for the next 2 years. So you need to deal with future upsurges in infection and also for locally relevant decision making. Next slide. You need, sorry, next bit. Yeah, trust. Go back. Trust is extremely important. And you need the accountability mechanisms to boost trust, to review evaluation, to advise on how it's going, to real-time scrutiny, as Sandra said earlier, of emerging data. And you need communities to feel engaged so that they know about the implementation, about any problems or solutions. Next point, next slide. You need data. It's got to be local data, and it's got to be fed back to people very fast in real time to get a local response. And you need data dashboards in the community that people will follow. And most important, and Alison will talk to this, about governance and safeguards for privacy and data misuse. And there are big, big concerns about the current centralized system. Next slide. And of course, as we've said, you may need, particularly in Hackney, you're going to need facilities for people who are vulnerable, have mental health problems, or are in very unreliable accommodation. We're going to need food for many people, particularly the elderly, and they may need finance, and you'll need appropriate guarantees from employers to ensure that people in isolation are not discriminated against. So these are big issues that need to be tackled. Next slide. And then you have key performance indicators. If you just click on that one more time, these need to be reported weekly, data that are timely, relevant, and useful, and again, with granularity to support your local decision making. So the next, just click one more time, Jareth. Yeah. So are the tests done and the result returned within 24 hours in your area? Do people with a positive test, are they being contacted within 24 hours to find contacts? Do those contacts or people share them with the call center if we're using a call center? Are they contacted within 24 hours? And do they crucially comply with isolation? And these are big questions. And so far, we haven't had any of that data from this central system. And we're going to need some of that data locally. Next slide. So just to finish, I was going to I mean, there are various scenarios that we may have to face. We may get a whole series of smaller waves, probably smaller than the first one, as in the first slide, which could go on for the next 2 years. You could have a second, even bigger wave as we go into the winter months, as Kevin hinted at. Or you may have the first wave and then really a slow burn that you're not going to get much in the way of a big wave, but you'll get lots of smaller outbreaks that have to be jumped on locally. Actually, there is a fourth one, which we don't, that this disappears. There are reasons why people may have heard the stuff about dark matter and possible hidden immunity and all kinds of things about behavior of viruses. So that would be the most optimistic scenario, but we really don't know what's going to happen, and we have to be prepared for all of this. Next slide. Finally, just to say, I can talk about the role of WHO if anyone's interested in the questions, because I work there. In my view, they've been scapegoated and fallen between the America-China dispute, but we could discuss some of that. Next slide. Is that the last one?
Yeah.
Yeah, finally, when will we get a vaccine? There are a lot of candidate vaccines. They are being studied. Oxford think that they've got a very good chance of getting one by September, but scaling it up will be a problem. Influenza vaccine is grown in eggs, and you can't do that with coronavirus. It could take a long time. I mean, there are lots of people focusing on this, and there's lots of clever molecular biology. But if we had a vaccine by this time next year, I think we'd be doing well. I'll finish there.
Thank you, Professor Costello. Thank you very much indeed. I'm now going to move on to Professor Pollock. She's the director at Newcastle University Centre for Excellence, and she's also locally to us, formerly at Queen Mary University. She also sits on Independent Sage, and she's going to talk in some more specific detail about the test, trace, isolate support. Professor Pollock.
Okay, well, thank you very much for inviting me tonight. I lived and worked in Hackney for quite a long time, so I know it really well. But I'm just going to start picking up where Anthony left off and actually touching Sandra's talk as well. And I suppose one of the most difficult things I've had to do, and I'm still not doing it well, is to ask the question, why is the government not following the legal system, the formal established legal system for notifying notifiable diseases? I've not explained it well to the Independent Stage Committee, so I hope I'm going to do better today. And the reason why this is important is because this whole system is based on GPs, NHS laboratories, and local public health. And it really depends on close cooperation between these groups and the generation of local data which actually flows locally every day. Now, COVID was made a notifiable disease on the 5th of March. And instead of the government following the formal legal established system, what it's done is bypassed the law, which is quite extraordinary because you know, the law is there for a purpose, and instead it's put in place a totally unevaluated, centralized, heavily privatized, fragmented system, which isn't working. We know that from the testing, the NHS app, and all the other pieces. And poor old Sandra is left picking up the pieces with the complex care groups in local authorities. So I'm going to explain how it should work and what the consequences of it not working are. And the first thing is, a case doesn't appear out of the blue. A case becomes symptomatic of patient, and they usually to their GP. In the case of COVID, it was NHS 111. And what should happen is that case is then defined as a suspected case, and that GP then would order a test immediately from the local lab, and it would advise the suspected case to isolate, and at the same time, it would make a notification to the public health service. So Sandra's group should be notified. And then they would contact the contact tracers. And when the test comes back, we hope within a day, then the contact, and it's positive, that case would go from being a suspected case to a confirmed case. And that is the legal notification system. All cases must be reported to public health, but they were not. GPs were cut out of the system. NHS 111 did not notify any of the suspected cases. So as a result, your contact tracing system couldn't even work if you wanted it to. The second reason is that GPs were not allowed to have tests, so you didn't know what the confirmed cases were. And also no testing was done in the community. Tests were all kept for hospitals until very recently. And even now GPs cannot order tests. So here are two pieces of crucial data you are not getting. The suspected cases used for monitoring the epidemic and telling you what's going on, and the confirmed cases, because there's much bigger caseload out in the community than there is in the hospital. Hospital and deaths are the tip of the iceberg. The other big problem you have is because you don't know what suspected cases are, because you don't know who's been what the test results are, because people have never been tested. You also had lots of deaths happening in the community where GPs didn't see them, they died on their own, and they died untested. So they go into a big clump of excess non-COVID deaths, but it's very likely many of them were COVID deaths. Now, the beautiful thing about the notification system is it worked. And it's being used in Germany, it's being used throughout Europe. And it turns on the medical practitioner. The patient has trust in the medical practitioner. They report to the medical practitioner, who must notify. The medical practitioner gets the test and feeds back the test to the patient. But what we've got is the government has put in so-called 5 pillars, and the NHS labs were frozen out, and they're still being frozen out. And instead, government contracted with these new lighthouse laboratories and commercial labs. The test results, of course, many of them have gone missing. Many have them not been returned, so you can't link them back into deaths or into cases. So we've got a real issue about the mess of the test, the quality of the tests done, because you get lots and lots of false negatives. Because if test swabbing isn't done by an experienced professional, then you're going to get lots of false negatives. So these are some of the issues. So as a result, there are no local data. The data are flowing to public health and the data should, under the formal notification system, flow locally, and only then should it be flowing centrally. And indeed, in Germany, it's against the law for anything but anonymized data to flow centrally. All the data has to flow locally, and it's kept there because of trust. Because the Germans, of course, because of their history, are very, very aware of the importance of trust. But instead of which, the government has contracted through NHSX with Palantir and faculty, big commercial companies. They have our security surveillance center, which is busy linking and aggregating data, selling it off. And the other thing that's happened is all the safeguards around our data have been relaxed. So researchers can now get free access to our data and our patient records. And this is another issue. The issues are so serious for the governance and trust in our data that the Joint Committee on Human has put out draft legislation, primary legislation, in order to try and protect data and against the NHS Act. So there are lots and lots of unanswered questions, and the biggest one is if, as our report is going to recommend, the government followed the legal notification system, then it would bring GPs in, and GPs would be resourced so they could look after symptomatic and suspected cases, and enabled to do community monitoring with nurses. Public health departments like Sandra's would be properly resourced and work with the regional field service. And the NHS laboratories would also be resourced and not frozen out. I don't know if I've communicated this well to you, but that is, we have had a formal, legal, established system, which is the government is now bypassing. It's not even following its own laws. I want to come on to the whole issue of care homes, because this is Sandra's real difficulty, people in social care and people in care. And of course, a big issue, staff. Now, there has been staffing and huge vacancy rates. These groups are often
Alison,
BAME workers, very low.
Might be worth turning your video off.
Yeah.
Because it's freezing quite a lot.
Oh, sorry. Can you? Oh dear, can you not hear me? Oh, have you heard me? Oh
yeah, we've heard. I think it's slightly better with your video off. So thank you. Yeah, we can hear you.
Okay. Have you had terrible problems hearing me?
No. I've caught virtually every word.
Has it been difficult to hear?
I've caught virtually every word. So please.
You caught most of it. Okay. I just want to come on to Hackney Trust at the moment, which is about to put out its contract for facility management workers. It's really, really important that these workers have full financial compensation where if they fall sick and or if they have to quarantine for 14 days. And that really is urgent, because one of the issues is low-paid workers on 0-hour contracts continue to work when they're symptomatic. They may not declare themselves, and they may not go into quarantine. So financial remuneration is vital, and as Hackney Trust seeks to renegotiate this contract in less than a month, this is a very big question to ask. The other issue is, of course, a huge understaffing, both in the hospital and in the care homes, And this has to be addressed urgently, because staffing is a measure of quality of care. And if we had redeployed staff into the homes, we would not have seen nearly so many deaths as we have now. Remember that while 70% of deaths in nursing residence were taking place in care homes, and they were dying alone, without medical care, and without treatment, and without family. So I'm giving you the picture, I hope, and setting the scene.
Thank you, Professor Pollock. That was incredibly insightful. Tracy Fletcher, who's the Chief Exec of our local hospital trust, and we'll let you come back a bit later on the contract point if you want to, Tracy, or in fact we can maybe do that on another occasion at another meeting. The last of our speakers is Dr. Amanda Healy. She joins us by telephone now. She's the Director of Public Health in Durham, and she's also chair of the North East Network that's been dealing with COVID. So here we have two regional leads in Professor Fenton and Dr. Healy. One of the factors that originally made us ask Dr. Healy to come is that Durham, I think, was one of the first areas in the country to team up. This is something Professor Pollock was just talking about, with its local trust, as I understand, to start turning tests around locally. So Dr. Healy might be able to talk to us about that and how they achieved that, and what possibly we could learn in Hackney, and also about the population health management approach that's been adopted in the North East. Dr. Healy.
Thank you, Chair. Can I just check that you can hear me? It was quite odd just being on the telephone.
We can hear you.
Great, that's lovely. And also just to say that I'm a non-medical director of public health, following my eminent colleagues. So I wouldn't want to have the doctor in front of me when I'm not. So I just wanted to say that up front. Thank you very much for inviting me here to speak tonight. Yes, I'm the Director of Public Health in County Durham. Just for your members, County Durham has a population of 525,000 people. It's one of the largest in the northeast of England, and it does still have significant health inequalities. Very rural, but also has a mining legacy to it. 1 in 5 of our population are over 65, and our healthy life expectancy is around about 58. Our approach, I guess, I was asked specifically to talk about the work that we have done locally, and focusing on testing. And it's quite interesting, building on what Alison has just said in relation to the importance of things that happen at a local level and the usual system that you would use, because we've probably ended up having to use a workaround. In County Durham, we have 96 residential homes. And the early approach was very much based on a joint agreement between our local foundation trust and their laboratory, and our local mental health trust, and working with our primary care networks and our local commissioning leads, because they are the people who work day in, day out with our residential and nursing homes, along with our infection prevention control team. And they wanted to very quickly build on any of the notifications that we were receiving from Public Health England to enable them to be able to work with the homes and to carry out local testing. What that allowed us to do very, very early was to be able to work very closely with those homes, and also to use the local laboratory capacity to enable results to be turned around very quickly. And that was particularly for the residents of the care homes. And it also meant that the residents were seeing their local community nursing team, who would be working with them on an ongoing basis. It also, we also managed to maximise the laboratory capacity for an agreement between occupational health and the local council, emergency services, to ensure that staff testing could be done through that route, as well, including some of our children who are looked after. I think what we found was that it was working particularly well. We have 4,000 residents across in our 96 care homes, and it enabled us to prioritise those. I think, however, obviously what we've heard from every speaker this evening has been the challenge of data. So we didn't have full data. We didn't have full data from the homes. However, we did test over 1,000 symptomatic residents, and just over half of them were positive, and 500 positive and 400 negative, and that enabled us to really focus on supporting those residents to be supported to isolate. Obviously, we've heard very importantly about that. However, I think what we've found locally is from the 12th of May onwards, the government obviously announced the whole home testing, and for all the letter that came with it talks about putting local directors of public health in control. What it really did was open up the portal for Pillar 2 testing to take place, and that took away control and support of locally from our GPs, from our community nurses, from our commissioning teams working directly with our local care providers. And what that meant was that we haven't known since then who was ordering the tests, how long the tests were taking, whether they were getting them back, the quality, the clinical safety of them. So that has been a real challenge for us locally, and certainly our cabinet member has written to the Secretary of State of Health in relation to that, and the issues that we've had with some of the Pillar 2 testing. We also, across the North East, have really tried to work collectively. So we had principles for testing in care homes and moving towards asymptomatic testing, and obviously not just one-off testing. And that also included, building on what Alison was saying about obviously staff, included staff testing. However, I think every time we've tried to look at a systematic way of doing that, something else is announced and is then comes down the line for us to almost thwart our effort. So they've been, I think, our challenges in terms of the Pillar 2 testing. I have had issues with our mobile testing units, and it has served to kind of undermine, I think, some of the local working arrangements. What we hope to do going forward is to harness some of that Pillar 2 testing, maximise our local lab capacity, and really focus on the ongoing outbreak control plan for our care homes locally, particularly looking forward and ahead to the winter period, and to try and do as much as possible through that local system that we've heard is so important. So I hope that just gives a little flavour of what we have been trying to do at a local level, jointly with our colleagues within our foundation trust and within our primary care networks and community nurses, and our knowledge of our care homes. I guess the second area that I just wanted to give a flavour of was some of the work of population health management. Now, obviously, I heard Sandra talk about the support for people in terms of our own community hubs. And initially, local authorities were asked to set up community hubs to support the local population who needed to shield. Now, across the North East, our prevention board, which is a multi-agency prevention board, has received funding to appoint consultants in public health within our local foundation trusts. However, alongside those, they are also employed to carry out work within our North East Commission support, which is really where a lot of our data and intelligence is brought together. And our population health management approach has been to draw together some of that data with our knowledge of the local community to really try and support and work with our local community during COVID and as the community hub was set up. At a local level, we were getting obviously the data nationally in relation to the shielded population, I think we were receiving it on a daily basis, and it was coming in groups of kind of 400 and then 1,000. And in County Durham, there were 16,500 residents who needed to be shielded. However, what we did with the population health management was overlay that with multiple vulnerabilities and the intelligence that we had, and our agreements, data sharing agreements in terms of multiple vulnerabilities, which included medical, so it was, you know, those people who were eligible for a flu vaccination, but also looked at social vulnerabilities and welfare vulnerabilities. So it might have been, we included some of our local authority data in terms of assisted bin collection, or fire and rescue service, primary care data, which helped us to give a richer profile of our local population who may be directly impacted clinically in relation to COVID, but may also be affected by COVID because of their wider vulnerabilities. So we kind of created our kind of risk pyramid and our triangle, and that enabled us, as the feeds were coming down nationally, to ensure that we were using that data properly, and we were able to cleanse that data to ensure that we were then reaching out to people who were in those different groups. Then that was then matched to the community response, and what it enabled us to do was to really work very closely with our local communities who were setting up local groups, obviously delivering food, delivering and befriending services, and the community hub and using the population health management approach enabled us to link the shielded population and people who may have been affected by COVID because of other vulnerabilities to that community level activity and support, including food, medication, welfare, and perhaps even just a chat over the telephone. So it was very much more kind of proactive than just waiting to contact people who needed to be shielded. It's very much relied on that community support, and it's been underpinned by our local wellbeing principles, which are focused on trying to do with people rather than to people. What it's enabled us also to do is to then ensure that people were access their usual services. So if it was vulnerable adults, we would ensure that it was through our vulnerable adults route, so that we didn't create something new and different. We ensured that we engaged with our existing services. The next steps, obviously, what we hope to do is to link that in as we move into the test, trace, and isolate, but are also thinking ahead to the winter period, and how not just that shielded population, but those that we have identified with other vulnerabilities can be reached through population health management, but connected through our local community and community resilience. So I hope that's given a bit of flavour of the work that we're doing, and that work's also been shared across the North East, and there are other examples. Newcastle, South Tyneside have used this approach in their work in relation to COVID.
Thank you, Dr. Healy, that's fascinating. I'm going to open it up to members to ask some questions, but I just want to ask two before that. The first one is to Professor Costello and Professor Pollock. I mean, with all the limitations that you've outlined in terms of the national vertical structure and the repeated problems, and this would be a controversial matter locally and require a lot of work, why don't local authorities just take back control, set up a hotline? If you've got symptoms in our borough, you call this number, and essentially create our own system as much as we can. I appreciate there'll be limitations as far as the testing aspect is concerned, but would you be encouraging local authorities to essentially take back control? If I can come to Professor Costello first, then Professor Pollock.
Answer yes. I mean, I just do not see how the current system can work. A testing system that's kind of all over the place. Can I just ask a question? In Hackney or Durham, can your GPs get a test yet?
Laura Sharp, can you say for Hackney?
Only for themselves.
I mean, to me, look, you've got the National Health Service. You've got a world-beating primary care system, frankly. I would use world-beating for that because everyone's registered. You've got data channels. You've got testing channels. If you set up in, I don't know how big Hackney is. Let's say it's 350, 400,000. Okay. You only need 10 GP hubs to cover 30,000 each. If not every GP wants to do it. You have your 10 hubs, you set up your hot rooms, you can go along. If there's only 5,000, 6,000 people testing a day at the moment, it means you're only going to get about, you know, I don't know what, I'd have to work that out, but, you know, maybe a couple a day at each testing hub. So, you know, you've got people there that can use PPE, you can do the test, you send it off through the usual courier, you get the result back the same day. And then you have to link contact tracing in. Now, if they're going to use masses of contact tracers, and most of them who rang in today were saying that they are sitting there twiddling their thumbs. Everyone that rang in said they've been working for 40 hours and they haven't had a single call to do. So, I mean, you know, personally, if I'd been designing this, I would have put contact tracers under local authority control, and then Sandra or someone would then distribute them out according to need, to go, and then they build trust into the system because they are then linked to the people that are providing care. Because if I was told tomorrow, or if I developed symptoms, I'd ring my GP or I'd email him, and he would say, he would reassure me, first of all, okay, I know a bit about it, but suppose I didn't, or people will be scared. They're going to be frightened. They're going to think I'm going to be in hospital in a week. I could be dead in 2 weeks. So they need reassurance. They need to be monitored. They may need to be referred if there's a problem. The GP will know all of this. They'll have all the data. They'll know about the contacts, the close contacts, because they're probably looking after the same people. And so the whole thing needs to be integrated, and that data needs to flow back to the GP and to the local authority. So Sandra has got that data. Now, how can you do that with home testing, which lowers the quality of the test? Because people, the tests are good, but the collection of this swab is the critical factor. And home testing and these car park tests done by Deloitte are not as good quality, frankly. Whereas if you have a trained nurse doing it at a GP's surgery, they're going to get a much better swab result. So I just cannot see. Now, my only hope is that Dido Harding, who is the Baroness in charge of all of this, will realise quite quickly that the results are going to look terrible, and she will change and try and tweak the system so that, first of all, you must allow GPs to be able to get tests. They can get tests for most other things, so why can't they for this? And you've got to get your data flowing back to local areas. But I think this is a big crisis, because if we don't get this right, we're going to have outbreaks. And you know, the government is not exactly in best position at the moment, and it will get even worse if this goes wrong. Alison should say something.
So I'm going to start with Matt Hancock. Matt Hancock could instruct Public Health England to work with local authorities, and he could divert the resources instead of squandering hundreds of millions on apps and commercial testing and Pillar 2 testing. He could really be reallocating those resources locally and also into Public Health England, but also into GP practices and surgeries. They need support as well. And so I think, you know, the example of Durham is really good, and there are other case studies around the country. We should also look at Germany. So what Germany does is it's decided it needed a team of contact tracer in every local authority so that it could manage 50 cases per 100,000 actually a week, 50 cases a week, but then they would have surge capacity, drawdown capacity. I don't think the local authorities can take the bull by the horn and do it on their own, but I think you need to be making really strong representation, and you should be working very closely with the GPs, but you can't do it unless you get the resource to do it. And And that means, you know, ending the contract with Circle, ending the contract with Randox. The contract for Randox, by the way, which is a commercial testing organisation company, is 133 million, and it was given for a month in the first instance. Guess how much the whole of Public Health England for communicable disease control has? 89 million a year. So, you know, I think we need to point this out. I mean, you won't be, the other thing you have locally is, you know, retired staff, volunteers. So you know your local community and local population. You'll need a lot of help from the Regional Epidemiology Field Service, and I'm sure Sandra's getting that, and also in Durham. So this is not straightforward, but it can be done, as Anthony says. It needs strong local authorities to be driving it and to be working with primary care and the NHS labs and trusts. Because one of the big problems now is you have lost health bodies in England. The loss of local health bodies makes it much, much harder for you because there is no area-based resident responsibility. But I think if there's a political will, there's a way. And I would urge you, you know, Hackney's brilliant at trailblazing. Everything you do seems to be great in your council. So I would urge you really to get on with it, but also to get experience from elsewhere. Germany in particular, I can give you contacts, but other places, even Scotland. Scotland still has health boards. They're doing their best. Unfortunately, they've got some of the pillar 2 test problems because they took Boris's kindly offer. So it's not all straightforward, but it's really working practically with public health principles there and working closely with primary care.
Thank you, Professor.
And I don't know whether, sorry.
Thank you, Professor Pollock. My second part of my question sort of dovetails on what both of you have just been speaking to. And can I bring in the Chief Exec of our local acute trust, Tracy Fletcher? Tracy, I mean, why can't I would hope and think Laura Sharp on behalf of the GPs would be able to get GPs that would be prepared to undertake swabs locally. Why? And I think Newham has teamed up with BART and are testing, if I've got this right, are doing some tests at BART. What are the limiting factors as to why the Homerton can't undertake local tests for us, or we work with BART to test, say, regularly care home staff or results that are coming into the GPs? What's the limitation, Tracy? You're on mute, Tracy.
Sorry,
I've got you.
I was trying to work out on mute. So our lab at the Homerton isn't set up to do these tests. You need quite a specific setup. So we ourselves use the Royal London, and for the tests that we're undertaking within the hospital, we get a pretty good service from the Royal London. The only time that there's been some delay was when there was some delay in the reagents availability, but other than that, the turnaround has been pretty good. But at the moment, well, with our lab, because of the nature of what the facilities you need within the lab to be able to do these tests, we can't do them locally. And at the moment, for the hospital, we've been getting a reasonable service from the London, and the London have been building up their capacity to be able to support more tests going through.
What, in terms of just that relationship with BART and the Royal London, I mean, if Newham, if I've got this right, are starting to do some of their care home, have we got a timeline for when we might be able to get some more tests online locally? And are discussions going on to sort of say, in 2 weeks, we might be able to have 50 more tests locally that we can offer to GPs? Are we talking about that locally as a way forward?
I can answer part of that, which is that we are talking about that locally with, there's some relatively local Northeast London level testing available, which is a bit outside of that national system, and which is how they did the work with Newham in their care homes. And we are talking to them about how we might be able to get access to that and be able to scale up some local testing. I couldn't give you a time frame on it, but in terms of the discussion with local labs, like say whether BARTs would have the capacity to do those, that would have to be part of the conversation, and how quickly they'd be able to scale up if either just City and Hackney or across the whole of North East London, we were doing more of those tests locally. I couldn't answer at the moment.
Okay. All right. Thank you, Sandra. Members of the Commission, can I go to Councillor Snell first? Any question from Councillor Snell?
Yes, please. So I think I've understood that we're close to having sufficient local testing capacity. Sorry, I'm an environmental health professional, so clearly I just do not understand why the notifiable disease process was not followed. It just seemed crazy to me. But the key thing is local testing capacity and then local contact tracing capacity. So I think I'm hearing that we think we can build up testing capacity adequately without waiting too long. So the question then goes back to Sandra. I mean, we as councillors have been really impressed with the flexibility with which council officers have been redeployed across into, contacting clients, identifying the vulnerable, all that hard work of getting people discharged from hospital in very short time and then giving them adequate support. It's been a fantastic effort by council staff. If you did take on that other level of contact tracing and following up, Sandra, would we have enough staff amongst redeployed council officers rather than wait for these completely inexperienced outside organisations to do it?
The short answer is probably no. We do have environmental health officers and public health specialists who could do some of that work. We don't have a lot of capacity, and in particular, as we start to, well, not necessarily get back to normal, but as some more of the lockdown restrictions are eased, then the environmental health officers, many of their usual duties, which are suspended at the moment, will they'll have to go back to, and possibly with a little bit more vigor as they're trying to support businesses to be more COVID ready, if you like, or COVID safe. So there's a tension there between being able to provide the capacity to do contact tracing and being able to provide the service that we need to do for the rest of the system, both in terms of keeping the community safe from the coronavirus, but also just normal activities and keeping businesses safe from other hazards. And then the other issue is the resources, as in finances or whatever, to be able to do that. Now, there's supposed to be some resources. There have been £300 million allocated to this to local authorities, but when that's going to be distributed and how it's going to be distributed hasn't been made clear, and how much of that we will need to allocate to different parts of setting this system up is also not clear. So we've already been talking with the community and voluntary sector about the kind of work that they're going to be doing for us, and that comes at a cost. As well as other things that we'll need to do. And we started the conversation talking about how we need to make sure that people in the community know and understand about COVID-19 and that they know that they need to get tested, etc. So providing those communications is also going to come at a cost. It's, however much money they allocate to us here, it's not going to be limitless. So we need to think about what can we do within the resources that we get, and how do we make. So what we're trying to do essentially is make the best of the situation that we are in, and the ideal situation would be that we continue to work with Public Health England, because they do have the health protection specialist expertise, but that we have more information, flexibility and resources to be able to provide a more localised response.
Thank you, Sandra. Councillor August Canley, do you have a question? Dennis, do you want to unmute? I'm not sure I'll come back to.
Can you hear me?
Question? We can hear you.
Yes, thank you. I don't have a good reception, I think, so I have missed some of the discussions, but my question is about testing and tracing within the existing legislative framework, whether we are doing all we can locally, and if there are things that we can do within limitations, as just explained by Sandra, if there are things that we can do that we are not able to do, whether there is any political support that is required at the local level that will help things moving forward. Thank you.
Sandra, I think that's probably directed at you again.
Yeah, thank you. I think the issue is really that is twofold. One is with the current system, we're not getting the test information. We don't know who or where people who are positive are. And Alison and Anthony Casso made really powerful arguments for following up and contact tracing for people who meet the case definition of suspected cases but haven't been tested. But as I explained a minute ago, we don't necessarily have the resources or the staff capacity to do that at the moment, and we would need to think about what the implications of that are as well, both in terms of not just whether we have the resources to follow people up, but also the implications of, say, isolating all of the contacts of a suspected case for 14 days. We would assume, I suppose, that we'd get a test result back quite quickly, but there's also the issue that depending on how the tests are conducted, that we wouldn't necessarily be confident that a negative test is necessarily negative, and so we might actually be advising people to continue to isolate for 14 days, which has other implications, including closing down a whole ward or a whole business. So we have to be mindful about what the impact is. But it's about balancing the risk of, is this really coronavirus, versus the other risks to people in terms of their well-being and the well-being of the whole community. But it's not to say we wouldn't want to pursue it. It's just that there are more issues, and in terms of what would be useful politically, I'd have to think about that.
Thank you, Sandra. We haven't got long left, so I want to get through the other councillors. Councillor Pluvier.
It seems to me that we've been thrown a sort of huge political challenge, which is that we can't do this. We need, as Councillor Kennedy has just written in the thing, we need the data and the resources. And for all Alison said very flattering things about Hackney, I don't think we ourselves are the people who are going to change the Prime Minister's mind. But I do think we have a responsibility to, as politicians, to take this to a London level and to work through London councils and with the mayor, because we have a responsibility, especially to our ethnic minority communities who've suffered so badly already. We have a responsibility to make the case for a better system. So it feels like we've been, it's not a question, I feel we've been challenged. I feel we need to look at that, and I'm glad we've had this meeting tonight. So thank you to the people who've come.
Thank you, Councillor Pluvier. I'll take that, as you say, as an observation. Councillor Spence.
Yes, hello. I wanted to go back to March this year, and the question about trust, and in particular why it appears that central government didn't trust the disease notification system that Professor Pollock described to us earlier on. And furthermore, why they appear not to have trusted the general practice to have a central role in all of this. And lastly, why they again appear not to have trusted local public health departments to have been central to the response to all of this. it seems to me there was a fundamental failure of governance at some point. And from that has flowed this process of centralisation and essentially sidelining resources locally which are not being used. We're not using our GP practices. We're not using our public health departments. It seems to me. I mean, that's the message I'm picking up, and I'd like to see what further comments people have about that.
So I don't know if you saw Councillor Hayhurst, but Alison had her hand up.
Yeah, no, I didn't. Thank you, Professor Pollock.
Can you hear me?
I can. Yeah.
I'll turn my. Can you hear me? So this is a really good question. However, you know that we've had decades of austerity, and basically public health departments, a bit like local authorities and environmental health, have been hugely eviscerated. And of course, what happened in the 2012 Health and Social Care Act was that communicable disease, public health was carved out of health services and put into Public Health England, and communicable disease control went there. And we've got enormous fragmentation. So we've got two things that are a problem: huge evisceration of resources and fragmentation. And of course, this has been happening in Germany as well. But what the government should have done is it should immediately have had a plan to restore and reinstate that capacity, use its environmental health, rebuild Public Health England. Indeed, it's in March, Public Health England wrote a note to SAGE, the government committee, and it's only recently been released. But they basically said they needed more capacity, and SAGE didn't respond to this, and neither did the government. So we are where we are now, but there is absolutely it's an ideological position that the government saw this as an opportunity for more centralisation and privatisation. And it's big pillar 5, it has 5 testing pillars. Pillar 5 is to build a commercial diagnostics industry. Well, since then, when has been a strategy to fight COVID? And the other really worrying thing is pillar 2, which are the commercial and the lighthouse tests. They're overtaking the NHS lab tests, which are falling. So a big ideological position here. You can understand them not using the GP practices to begin with, but they should have involved the GPs. And indeed, we've got a situation where NHS 111 are not returning very good data back to the GPs. So the GPs don't know about their patients, and they don't have the tests on the patients either. So this has been deliberately eviscerated and then completely bypassed. And that was a political and ideological decision. That's my response.
No.
And they could have fixed it if they had wanted to, and still fixed it.
Thank you, Professor Pollock. I've got one more member of the commission to ask a question, and I've maybe just got one to finish off, and then we'll close the meeting because we're nearly out of time. Councillor David.
Yeah, hi. Can everyone hear me?
Yep.
Yeah, thanks to all the speakers. There are just 2 quick areas I want to touch down on. Firstly, is it safe to open schools given the disproportionate impact on Black, Asian and minority ethnic communities? Should we as a council take a stronger stand on schools reopening, say, for example, our own council tests or criteria, as it were? Now, the second area is test and trace. I mean, the different categories of people. I mean, for example, the test and trace app is not going to work for people who do not have access to mobile data or who will not pay mobile data for the government to track them. I know there is the call system, but then it's not everyone who's going to be willing to hand you phone calls of everyone else they've come in contact with. But most importantly, I think everyone speaks about contacting people who has a suspected case or actual case has been in contact with. But have we been making the case or advertising to people to keep a diary of who they've been in contact with for a certain period going back? So say, for example, we have we have, for example, like epilepsy monitoring books, which they use to monitor numbers of seizures. We could have those kind of booklets, because not everyone's going to remember who they've been in contact with 2 weeks prior. And I don't think people are being told, you know, we have more opportunity to go out as many times as possible. So, you know, people could forget.
Thank you, Councillor Daly. Can I ask Professor Costello, in terms of schools, should local authorities have their own criteria, a certain number of infections, recommend closure? Should local authorities be more active on that? What are your thoughts?
Well, we came up with a school report just 2 weeks ago, wasn't it? And we said at that time, first, you want to know how many infections are in your local community. You know, are you a declining area or way down, or are you a rising area? And have you got an efficient find, test, track, isolate, protective shield there for people? We quantified the risks using some new modelling approaches, and we showed that the risk of a child going back to school on June the 1st, using national data, was roughly to be exposed to another child there, 1 in 25, to actually become infected was about 1 in 50. And of course, the risk of death is absolutely tiny, because children, by and large, will either be asymptomatic or have a mild illness. But the risk, of course, is to their families back home. And if you've got high proportion, as you have in Hackney, of Black, ethnic minority and deprived populations, then they will be more at risk. So we recommended a delay of 2 weeks from June the 15th to June the 1st to June the 15th, in order to allow find, test, trace and isolate to get more settled, and to allow the number of cases to go down. The trouble is, we don't know how many cases are around at the moment, it would seem. And we don't have a very effective find, test, trace, isolate. And the R0 figures that are being pushed around are 2 to 3 weeks out of date, because that's the nature of measuring R. So we're in a difficult position, and I don't know what to advise you, to be honest. I mean, if you think that the level of infection in Hackney, because London has gone right down, is pretty low, and you've got something moving, then a lot of, you know, you've then got the risk of children not going to school. So I think it's a very difficult decision for you. I don't know whether Alison would want to add to that.
Professor Paula.
Yeah. So I think that is and as Anthony says, you're not a physician because you don't have very good data either way, and you don't have a good system. But I think there is a case for really thinking about the children, and how one of the recommendations is that we don't want children to have 6 months of lost time, and think about how you might give children a summer experience all children over 6 months, and, you know, access to food. We were recommending using football stadium, rugby stadium. There won't be any of those in Hackney. You know, playing fields, parks, even private schools. Really being imaginative and using everything at your disposal. People feel very strongly about a community action, because we've got to give children back this lost time. And, you know, the Children's Commissioner, people are talking rightly about the scarring on children, and many of them are in very vulnerable circumstances. So not returning children back to school doesn't mean we can't be creative and do other things for them. And I think that's really, really important to stress. We don't carry on doing the same as before.
And your risk of getting the infection or transmitting it is way lower in the open air, if you're in an enclosed space, but if you're in the open air in a park or somewhere. So the idea of open schools was something that was practiced for about 100 years, up until the 1950s. So the idea of giving children an opportunity over the next 3 months with open air schools, open air classes, open air sport, positive experiences is something you as a council, I think, could think about really creatively.
Thank you. I've got our CCG.
I lived in Victoria Park. So there was one in Victoria Park, an open school in Victoria Park until the 1950s.
I certainly didn't know that. Was fascinating. I've got Mark Rickett, to our CCG chair.
The test and trace.
Mark, before you come in, can I just, the second part of Councillor David's question, can I just direct towards Professor Fenton? I mean, what Councillor David was talking about, partly about people with epilepsy keeping a diary. What we saw in South Korea with one of their outbreaks, I think in the nightclubs, is all the nightclubs were taking a list of everybody going in. So to what extent is there for a role for local authorities and on a pan-London level and or for all regions to be thinking creatively in terms of licensing requirements about keeping lists, so it enables to facilitate a much quicker track and trace process for those clusters, and whether you've got any thoughts on that. And the other area, Professor Fenton, I wanted to ask you about is in terms of something Professor Costello raised, in terms of actually finding the cases and the lack of trust in communities. I mean, that on sort of the cost dynamics seems to be a fairly less expensive option in terms of communicating messages to different communities. What sort of practical suggestions have you got for local authorities in that regard?
Great, thank you. So to your first question, absolutely, there's going to have to be opportunities for innovation, and there's going to have to be a lot of innovation because we're moving into an unknown territory in society when it comes to living with COVID, and how do we re-enter society in a way that minimizes the risk of transmission, that minimizes harm, but that allows us to continue with daily life, living, restart the economy, take care of our health and well-being, reconnect socially. So in order to do that, there are going to have to be trade-offs. But within that, there's going to be innovation as well. So within thinking about innovation, the app which is being developed, for example, is certainly one way in which you could automate ways in which individuals who may have had prolonged contact with others to be notified if there is an infection risk. But there may be other strategies which will become emergent as we progress into this new phase. We may learn from other countries on innovation in those countries that may be adaptable here, and we may develop some of them ourselves. So I'm very much in that space of being open for innovation as we move forward. Your second question, I'm sorry, Ben, was about?
Was in terms of something Professor Costello made and an independent sage came up with today in terms of finding the cases and how certain communities might be less likely to report symptoms, and what we can do as local authorities to think innovatively to speak to different communities to get the message across.
Fantastic, thank you. You know, we've been doing so much great work with London councils on exactly this. And I think Sandra mentioned this earlier in one of her responses, which is instead of in an environment where resources are scarce, and we are looking at how do we create a contact tracing system at scale, we need to be really careful about duplicating activities at every level in the system because it's not going to be effective. But what we can do, and I really support Sandra on this, is identifying what are the unique capabilities of local authorities and how they can use that to wrap around and to support the contact tracing system as it's being developed. So some of your unique capabilities include your ability to reach out to local communities, to engage them. There's a need for culturally competent health promotion messaging, culturally competent messaging about testing and contact tracing that needs to be done, and that's best done at the local level. At the local level, you know your businesses and you know your workplaces. So if there are workplace outbreaks, your ability to go in, work with your businesses, work with business forums, work with those local networks will be essential. At the local level, you know your care homes, you know your prisons, you know your hostels. In Public Health England, we can provide the technical advice. But again, it's the relationships that you build now that will put you in good stead for responding to outbreaks effectively in the future. So thinking about some of those unique capabilities will certainly be really helpful in maximizing the effectiveness of the contact tracing system. Now, as capacities are built in local authorities, certainly Sandra's team, looking at how you build the wraparound support for Sandra's team in the local authority, then we can begin to think about other functions that you may want to take on. But in the meantime, I would really encourage you to think about what are the activities that you uniquely can do that can provide that wraparound service for the contact tracing to be successful. Hope that helps.
Kevin, just one quick question.
Sure.
How can you avoid this bypassing of GPs? Why was that decided? And why can't GPs test, since they're the people going to be looking after the cases and contacts?
So I can't answer why, but I can speak to some of the practical day-to-day issues that primary care colleagues will face, including how do you manage infection control within the primary care setting? How do you reduce the risk of onward transmission, especially in that first phase of the epidemic? That was a big concern when we had unchecked community transmission, certainly at the beginning of the epidemic, and we had to manage that carefully. So I think there's some real both infection prevention and control issues. There are capacity issues that we also have to deal with as well. So I would think that we would have to be really careful before saying that we should just open up again to primary care to do everything.
But not do everything, but most GPs say to me across London, they have the capacity, they have divided areas, they can do infection prevention and control, they can get the test done. Not everyone, but you only need 10 hubs in Hackney. Wouldn't that be possible, and to then feed into the system? That would be much more efficient, and you get the data back to them directly.
Yes, one of the things to remember, Anthony and colleagues, is that the guidance says that if you are symptomatic, that you should actually stay at home, because you want to reduce the risk of onward transmission of people walking to a primary care centre, to a testing centre, etc. So part of the guidance is about staying at home and then being tested from home as a more effective way of managing both sticking to the isolation guidance as well as managing the onward risk of transmission. So again, I think there's some innovative things that we can be doing. The system is getting better at getting the tests out, the home testing. I acknowledge some of the limitations of home testing, but as the technology evolves, that can be a really effective way of doing that. We already do it for HIV testing and STI screening. The technology will allow us to do this really, really well and really quickly. And in the meantime, it's about understanding, I think, how we ensure that a system has been created, how we optimize it, and that can only be done by working together and helping the system to work together as effectively as possible.
I've got Dr. Mark Ricketts, who's the head chair of our CCG, who's been waiting patiently to come in. Mark.
Yeah, thank you, Ben. I just wanted to make one or two comments, and it flows quite nicely as a segue from just the preceding conversation. I mean, certainly, as of today, we can now order antibody tests, but Sandra's right, only for our members of our staff. So that has come on the stream. So it's progress, but slow progress. Antigen testing, swabbing, would love to be able to do that in primary care. I think you could do it in practice level, at a network level, confed level, community services, other people, hubs, etc. Probably the offer would be a mixture of all of that. But actually, quite a lot of the time now, we're trying to encourage practices to get back to not only managing the emergency care needs of the community, but also restarting with the essential routine care. So starting with things like immunizations and dressings and all the things that really need to be done, and then moving into working in other areas like managing the usual work around supporting the frail, the vulnerable, people approaching the end of their lives, people suffering with long-term conditions, these people with diabetes, respiratory disease. So there's a lot of other work going on, which the COVID response would need to fit into. So there is the IPC, the Infection Prevention Control Challenge, and the capacity planning, and it has to be put into that wider context, I think. So I just wanted to make that point, because a lot of other work is going on. And of course, we've got the new video and other modalities of the way we go about our work, home monitoring, much more assertively done. Maybe there's a role for an enhanced home visiting service, as well as care home, etc., etc. But one last thing I was going to say was about the data and the fact that notification seemed to be formally sort of suspended at the height of the pandemic in the spirit of, you know, let's strip back all the stuff you don't need to do. But I just wanted to say that we have, at Hackney, we got close relationships with the clinical effectiveness group at Queen Mary Westfield. And I know the scrutiny committee members will have heard about the clinical effectiveness group and its incredible value to not only City and Hackney, but also across North East London in terms of helping support clinical decision making and gathering data and business information, etc., etc. And we've been entering suspected COVID cases against a code that the clinical effectiveness group can anonymously extract and provide practice level data, which can then be aggregated against networks and neighbourhoods, etc. Now, it's been taken a while to get practices to use that template because they've got lots of other things they're thinking about, but we are pushing more and more that should be the case. So there is a possibility we could get good local data around suspected cases. Confirmed cases are notified by the labs who confirm the positive results. But the suspected cases, we could probably try and get better, you know, using our local information better than we are, perhaps. And it's just for people to know that is a potential source of really helpful information when we're planning this response.
Thank you, Mark. I think data is something that's clearly, I think, most people are in agreement with. I think it's certainly something we can continue to lobby on a political level upwards for the need for maximum data to come back down. I think those will know we had a measles outbreak last year, and it is exactly the same issues about real-time data flows that were prohibiting a speedy GP response. So it's the same thing that we're seeing. Thank you, everybody. I've run over by 15 minutes and there's still a bit of housekeeping left on the agenda. So I don't wish to detain people anymore. Thank you all very much for coming. So all our invited guests, thank you. Please feel free to leave. And the members, if you just stay for 5 more minutes for a bit of housekeeping. Thank you very much, everybody.
Thank you, Ben.
Thanks, Ben.
Thank you, Ben.
Thanks, Ben.
Thanks all. I think I've got members and a few others here still. So basically, what we've got left on the agenda, everybody, is the election of a vice chair, because there hasn't been an AGM. And so what we suggested we do is, if we have we've got 2 candidates, Councillor David and Councillor Snell. Councillor Spence has withdrawn. And so my suggestion is that we have a 2-minute husting for each of those people to have a 2-minute husting. And then in July, for the July meeting, we can take the formal vote then. So as to make use of this time now, Councillor Snell and Councillor David, I've got for 2 minutes. I've got no. Who wants to go first? Any preference? I can't hear you.
I said Peter can go first.
Okay, Peter, if you're happy to go first.
Okay, Sandra is still on here. I don't think she wants to see this, does she?
I think she's leaving. She's leaving. So it's just, we've got John Williams from Health Watch Hackney, Councillor Gregory, and then some IT support and the officers. So I think, if you're happy with that, are you happy to proceed, Councillor Snell?
Yeah, can do. Okay, so I alluded to it quickly earlier on. I mean, I come from an environmental health background. I do understand the whole way in which public health function has been developed in local government. I'm very critical of the way environmental health has increasingly been subsumed into a regulatory role, and that's part of the reason that we are suffering at the moment from lack of local capacity. Ben clearly was a director, I think, at Homerton for quite a while, and has got loads of expertise in the area of NHS care. What I would hope to bring to the role of vice chair is experience of the public health function, which is really I think gets a bit neglected. We get all these big reports from the various hospital trusts and everything else. And in particular, if we pick up on what Kevin and others were saying today, there's a need going forward to use our capabilities in local government to support the tracking and tracing process. And one of the things that COVID-19 has made more clearly is the truth that was always there, which is that health inequalities come from income and environmental inequalities. And if you look at where the cases are based in Hackney, they're in overcrowded housing, they're in poor housing conditions. And what we should be doing, and we can do, because I know there's good practice. I used to organise sort of public health get-togethers for the Chartered Institute of Environmental Health. I know there is good practice in other boroughs across London where, in the same way they're now tracing extra things with DPs, they can trace the contributory factors to COVID-19, and then we can use our officers to go in and address those issues.
Thank you, Peter. Nicely, just in time. Councillor David, over to you. You still got the speaker on, Kofo?
Oh, sorry.
Start again.
Oh, yeah. I'll just start by. Yeah, can you hear me now?
Yeah.
Yeah, I'll just start by saying that I've got extensive experience in the healthcare sector. So I've been a governor in East London NHS Foundation Trust for over 6.5 years. East London NHS Foundation Trust deals with mental health services for Tower Hamlets, Newham, City and Hackney, Bedfordshire and Luton. Now NHS Foundation Trust is quite different from an NHS trust. And I understand now that Homerton has become an NHS Foundation Trust. I was part of the small group of governors in Elft, which helped to draft the constitution to fit into the amendments of the Health and Social Care Act 2012. We really need to understand how these foundation trusts operate to actually hold them to account, because there are different powers, there are different ways they're regulated and different ways they operate. Now, I was involved with the project with the Epilepsy Society. That's the largest epilepsy charity in the UK, when they did a trial program in Hackney, which was meant to kind of track epilepsy seizures and communities which had been affected by that. I'm a governor in St. Mary's School. Obviously, we know that schools are an issue. We've been discussing about how the potential of schools being a petri dish of spreading this COVID is. I'm someone who's from the most affected community, and I think that I do have a grasp, nut and bolt grasp of what really happens. I know the politics within the NHS and how to get things done. And I think that's what we really need, someone who can scrutinize and look at things. I mean, one of the questions which I raised now was not, kind of looked into properly. Plus, I think from the diversity angle, I think that it's good for us to have a representation in the council scrutiny committees and commissions. I think we don't have any black man in any scrutiny committee or commission as a chair or vice chair. So I think, Black Lives Matters. We can't turn on the council lights and not practice what we preach. So that's my take.
Thank you both very much for two well thought through hustings. I said in the pre-meet, Dennis, I don't think you were there. What we'll do is, because of certain formalities, we will take the final vote in the July meeting, but we do the hustings now, and I will have the opportunity to email everyone just in terms of that. It's good because we're all here, so we all heard it as members of the committee. So thank you all. No other business has been notified in terms of the work programme. Just to discuss this going forward, we've got a July meeting, Health in Hackney meeting. There's the ISS contract, which Professor Pollock referenced. Now, the Homerton are due to sign an extension to that at the end of June. Because of this agenda item, we didn't have time to fit it in today. My proposal is, in the interim, to write to the Chief Executive at Homerton, asking some questions about that in light of the previous matter that's come towards us about concerns about that contract and about 0 hours, and ask for more details and clarity. So I'll send that letter off in the next few days. And then I think we'll have the opportunity, hopefully, I haven't yet confirmed with Tracy that she can come to us in July. And then I think also things are moving quite fast in terms of integration in the local system. And so that's possibly another topic area. But I also think one of the benefits of this is we've kept it quite flexible. So we don't know quite how the COVID pandemic's going to develop. So there might need to be some flex in terms of if there's a particular area we need to look at. So Peter?
Just to say, there's normally some flexibility, even if they're going to extend the contract. Normally, you can update a contract to take on board emerging issues. So even if they argue, sorry, can we probably best if we see the letter in advance, because we should be saying even if they decide they do need to extend the contract, then we do make sure that there is proper sick pay and the other safeguards to ensure that there is not underreporting of COVID and similar infectious diseases.
Yeah. Okay. I've got that point. Yes. Fine. We can include that in. I think that's a very important point to include. I'll include that. Thanks everyone. So I think I'll probably not. My suggestion is I'm not going to formalise the agenda, but the rough sketches to certainly have ISS, to certainly have Hackney integration, and what's been going on there, and then possibly a third item depending on where we are with COVID, perhaps following up perhaps with Sandra on some of the more local specific things that we can do, might be an idea. So unless there's anything else, I'll thank you all for coming, and Jana's just reminded me, in LREP, we've got an Inner North East London meeting coming up, and Yvonne Maxwell was the rep. She's obviously gone to a cabinet advisor. Any takers for the INL position? I've got Councillor Snell. Anyone else? I see Michelle. Michelle, you've got to be on the committee before I can take you. So if you come on the committee after the AGM, that may be we can take you there. But so I've got Councillor Snell. Anyone else for the INL rep?
I was going to go for it, but I'll just pull out and leave that for Peter.
I think you're on it already, aren't you, Kofa?
No, sorry? No, I'm not.
Oh, sorry.
Okay. All right then. Okay, thank you. Then we appoint Councillor Snell to the INL position. Does anyone disagree with that? Fine, take that as unanimous. So with that then, thank you all very much for your questions today, and I'll close the meeting.
Sorry, minutes of the last meeting. Somebody was reminding you minutes of the last meeting.
Oh, yeah. Sorry, thank you very much. Minutes of the last meeting. Does everybody, any observations, or are they agreed?
Agreed.
Agreed. Perfect. Thank you, Pete. Thanks, everyone. Okay, with that then, I'll close the meeting. Thanks all.